It is 8:05 p.m. Good morning, good afternoon, good evening to everybody, wherever it is you are joining us from. Thank you so much for taking of OAU 2005 OAUMedtalks, the Edge series. And it's my pleasure to welcome us to the program today. My name is Adebayo. I'm a public health physician. I practice my brand of public health communications in Nigeria, and it's an honor and a pleasure to be on our way today to introduce to us another fantastic, interesting episode of this series. We've had fantastic speakers. I hope I was one of those that was fantastic. I know we've had some fantastic speakers. I know I've spoken on one edition today. I hope I qualified to be one of those that was fantastic. But I know we've had really, really great people share from their wealth of experience. I've learned a lot. I've been encouraged from the previous editions. And today we have somebody back then, we call him Prof. And I know he's still very professorial. He's here to share with us today. He's a fantastic person, and that's in the person of Dr. Akintunde Akinola, fondly called Prof by us. Dr. Akinola is a certified American Board of Family Medicine practitioner. His practice is focused on hospital medicine, particularly adult inpatient practice. And typically, Dr. Akinola will see over 3,000 patients every year. He works primarily at the Mercy Medical Center in Cedar Rapids, in Iowa, where he sits on the trauma, ICU, and code blue committees for the hospital. Dr. Akinola is also a senior partner at Sound Physicians, which is a 20,000 strong medical group of hospitalists, internists, emergency medicine, physicians, and anesthesiologists. So it's without wasting too much time, Dr. Akinola is going to have the floor for about 40 minutes, 40 to 45 minutes. If you have questions while Dr. Akinola is speaking, please feel free to just drop your questions in the chat room while he's speaking. We still have a time to interact as at the end of the program, but before the question will fly away from your head, if you feel you need to ask something, please just drop it in the chat. We'll take notes of them and answer all of them at the end of the session. So ladies and gentlemen, please welcome Dr. Akintunde Akinola. Prof, over to you, sir.
Thank you so much, sir. That was very kind. Like he told you, I'm Akintunde Akinola, and yes, I do practice hospital medicine in Iowa, Cedar Rapids, Iowa. What we call hospital medicine here basically would be internal medicine back in Nigeria, just that it's focused on the hospital side. So for the past almost 10 years, I've not worked in a clinic. I mean, very rarely I might go do a pre-op assessment, but to actually go and work in a clinic, I haven't done that in a long time. And as you see on your screen, what we're talking about today is what's in the medical specialty, what really matters in terms of what I have to choose or what I should choose when it comes to postgraduate training. I want to acknowledge my colleagues, starting with Dr. Adebayo, also Dr. Awuyale, and the other organizers. I see a few others online, Dr. Tegbe and others as well. Please, if I didn't mention your name, it was not intentional. So we're going to, dive into the subject without further ado. These are just introductory things which Dr. Adebayo already touched on. So the challenge of postgraduate medical education is what we really want to talk about, because it could be life-altering, life-changing, the implications of what you choose after you're done with your basic medical degree. I mean, I'm not sure of the level where our students' population is at for our students who are online today. Maybe you're clinical, preclinical, you're done, you're about done. But regardless, it's going to be a very open discussion. I anticipate having some more time available than what my colleague allotted. I might finish sooner than that so that you can ask questions, and my colleagues would also be on hand to drop in a thought or two. Just before I start, a little disclaimer. It's been a while since I actually, practiced within the Nigerian context. So if I say something that's either off or not accurate, please just jump in and correct me. We're a family. Nobody knows it all. So anything after 2007, really, I can't speak to it accurately. But that being said, this applies, what we're going to discuss applies wherever you choose to practice. So again, the topic is what's in a specialty? What really matters? So a few things to look at. Number one, what is my purpose? What am I trying to achieve? Do you know, even coming into medicine in and of itself, this is something we should be asking. But thinking back and looking at it when you were in science class and everybody like, oh, my child will be a doctor and engineer and that kind of stuff. It's not everyone who can say, oh, absolutely. My purpose was tied to becoming a physician. So, but we're past that. You passed your UTME, you got into medical school, you're probably done with preclinicals already. So we're past the issue of, is it my purpose to be a physician or not? Whether you like it or not, you're at a point where you have to graduate, you have to become a physician. But you still have to answer that question for yourself. What is my purpose? What is that which 40, 50, 60 years from now, looking back, I'll be able to say, in doing this, I fulfilled purpose. And frankly, if it's not in medicine, don't feel lost. Get your degree and use your degree as a launch pad, as a springboard to get into what you really want to do. I'm sure you listen to people like Dr. Sashiun, Dr. Emmanuel, Tunde Afolabi, and some other people, Dr. Yesufu. These are people who are doing really well, even though they're not actively practicing clinical medicine. That does not take anything away from their purpose. So number one, what's your purpose? Number two, wherein lies my passion? You know what passion is. Passion is what keeps you going when the going gets tough, when it's extremely difficult to persevere. So if you had a very nice ophthalmology posting and you liked it and you gave it a thought that you want to become an ophthalmologist, that's great. However, you will have some encounters either in training or in practice where you'll be like, whoa, this is difficult. In those moments, only your passion would keep you going. So purpose, passion, they're all tied together. And then your possibilities. What I mean by possibilities, I'll also touch on in the next slide here. So the purpose provides direction. Like, okay, this is what will bring meaning to my life. Please understand, medicine might be your means of livelihood, but medicine should never, ever be your life. Your life should consist of, your relationships and things that are much more important than just, what you studied in the university. But not to go too far into that, you have a purpose which will provide direction and inspire your dedication to that direction. Then, of course, your passion. Passion is what will keep you in there, even when everything around is discouraging. So whether you practice, back in our native country, you move to the West, there will always be challenges, but passion is what would keep you going. Of course, the passion can be developed or it can be dampened. It's a question of the individual. So there's really no specialty you cannot get into, you cannot practice. It all comes down to these three things. What the third one is the possibilities. So sometimes because of, prevailing circumstances, it's very hard to get into some kind of specialties. And if you have a purpose, you have a passion, well, most things are possible when you're ready to stick at it. But sometimes you really have to be pragmatic. How old are you? What's your family background? What would this take away from your life if you had to spend another 7, 8 years to pursue something that may or may not work out? Are you married? Do you plan to be married? What would your life outside of medicine look like if you were to insist that I have to do this? I'll give you an example, of course, without names. I know of a physician from Nigeria who came here, did some exams. It didn't turn out so great. So it's like, oh, but I really want to be a surgeon. I can't, do anything other than surgery. Okay. So what did he decide to do? He went to get a master's degree in surgical assistantship. Okay. So he became a surgical assistant, like scrubbing in with the surgeons and all. And then he then applied to medical school. Okay. Medical school here is obviously a 4-year postgraduate course. So now he's in medical school and he's planning to, after that, go into surgical residency. Don't forget, this is someone who actually had gotten into residency back in Nigeria before coming this way. So, I mean, at that point, it becomes a matter of pragmatism. So if you're going to give another 10 years of your life to pursue this goal, it becomes your answer and your answer alone to the question, is it worth it? Is it really worth it? Is this something I should be doing? So enough about what I call the foundations. Let's keep going here. Just a brief overview of specialties. And with due respect to my colleagues, if I did not mention your specialty, please, you're gonna help us and jump in and complete it. I don't lay claim to perfection here. So of course we have primary care and we have specialty care. Primary care basically, at least the way we look at it in the US, entails general surgery, medicine, pediatrics, and psychiatry. So like when you do your house job, those things you go through would constitute primary care out here. So in medicine, of course, you have internal medicine, family medicine, emergency medicine, and those have a lot of overlap. So I almost always get, job offers multiple per week. Do you want to come work in an ER? No, I'm completely fine with hospital medicine because I'm just glad to go into work every day, deal with the heat of the day. And when I'm done, I'm done. I'm not like carrying any insurance papers, anything home. The day is over, I'm done. I'll be back tomorrow. So that's why I like hospital medicine. Well, of course, you also know about obstetrics, all the peculiar needs of, the female anatomy, reproduction, pediatrics, the care of the children, and of course, psychiatry. So all that falls into primary care. Well, why would you call them primary care and not, specialty secondary care? It's because these specialties, these primary care specialties, encompass what everyone goes through. Everyone on this line has had an encounter with any of those specialties over the course of a lifetime. Somebody took your delivery, somebody gave you the shots, somebody, took care of you in one way or the other as just a regular, medical provider. So we're still going to go into a little bit of comparison, not like one is better than the other, but the point is primary care has the breadth of scope. It has the breadth, and we're going to talk more about that later. Going into specialty care though, when you now say, okay, I want to gain mastery, I want to become very proficient at taking care of rheumatologic issues or urologic issues or plastic surgical issues, then you're talking about specialty care. And that's beautiful because you're sacrificing in order to learn how to take care of specific problems, not the most common problems, remember, but specific problems, and you're going to be the one we come to when those specific problems come up. So if someone breaks his or her nose, you know, not so uncommon in the West because of the kind of, are they having CSF rhinorrhea? Do they need more intervention? Of course, I'm going to call a maxillofacial surgeon. The question is, how many times does that happen in a month? Not often. Not too long ago in my hospital, the hand surgeons were trying not to be on call because when you're on call, you can't leave town. Now, how many times do we have specific hand surgical issues in my hospital? Not very often. So my point is, when you're going for specialty care, you're committing yourself to become the master, the mistress, the best at a specific line of, medicine, and you are going to be the one we come to when we need help, like specific help, and that's great. So as I have there, plastic, orthopedics, vascular surgery, urologic surgery, cardiothoracic, neurosurgery, ophthalmology, anesthesia, and of course, in the medical side, you have rheum, cards, pulmonology, intensive care, infectious disease, pathology, and the list is endless, So carrying on, I still kind of broke it down a little bit more. So even in primary care, you can still go further. You can say, okay, I'm done with my peds. I want to do pediatric endocrinology. So you take care of all the pediatric diabetes, congenital adrenal hyperplasia, that kind of stuff. Pediatric cardiology, pediatric GI. In family medicine, at least out here, we have also other options, geriatrics, addiction medicine, focused practice in hospital medicine. Like I mentioned earlier, hospital medicine is my area. Palliative care, HIV care. There used to be an HIV, I believe there still is, an HIV fellowship where I did my training. Low risk obstetrics, sports medicine, sleep medicine, and coming also to emergency medicine, the same thing. They have their own subspecialties too. Please note that these things vary from country to country. Most of the things I put here were pulled from the ABMS, American Board of Medical Specialties. So people like, Dr. Olaseyinde and other people can help me in terms of what's available to us in Nigeria and West Africa. Talking about psychiatry and OBGYN, you also have some other things there. Now, coming again to the specialty care side, you could still subspecialize. So colorectal surgery, hepatobiliary surgery, breast reconstruction surgery, bariatric surgery. Again, as science evolves, equipment becomes more available, people get more training. So in my hospital now, you have all these GI doctors. Of course, they do tons of colonoscopies and EGDs, endoscopies every day. Like that's the bulk of what they do. But again, somebody sends a stone into their common bile duct, they have obstructive jaundice, or they have pancreatic cancer. You need to do an ERCP. You need to put in a biliary stent. Well, because there are so many GI doctors, you now need an additional fellowship, right? To learn how to do an ERCP. So they spend an extra year just learning that procedure because you have to be proficient. You're not a specialist if you're not a master of the area you're specializing in. So that's the sacrifice you're making. Radiology, of course, you have interventional radiologists. You have neuroradiologists who are like extremely skillful in reading images specific to the nervous system. So all these, like I said, specialties keep evolving as science evolves. You have all these minimally invasive surgery fellowships, pediatric People learn how to use anesthesia, pain management, critical care, cardiothoracic anesthesia also exists. Like when you're talking of these kind of specialties, you're really narrowing yourself down to become extremely good at some specific patient population. Of course, cardiology is very, very, very central to the practice of medicine, because once the heart is gone, we're gone. So you have electrophysiology, folks who put in the pacemakers and all. We have interventional cardiologists. I know we had Dr. Adebayo here not too long ago, cardiogeriatrics, echocardiography, sports cardiology. And under neurology, you also have things like headache medicine, neuromuscular medicine, neuro-oncology. So these are all areas of medicine that you could pursue based on, again, purpose, passion, possibilities. So let's keep going here. What is the, I don't want to say pros and cons, let's just look at each versus the other. On the side of the generalist, again, these are just coinages that are common in America. The generalist obviously is someone who went into primary care, while a specialist is someone who went into specialty care. The generalist has the breadth of scope. So if you call me at 10 a.m. in the morning, I might be tucking away a DKA patient, get the insulin drip going, close the anion gap, correct the hypokalemia, get all those things sorted with the DKA. In another might be in the birthplace where people say, well, have you? The specialist has the depth of mastery. So I just mentioned OB, right? There was one night I was on call, and the OB on call had a diabetic lady, and the sugars were just running haywire. If I remember, she might have been in DKA already, open anion gap, pH was terribly low, and he was on, what do you call this thing? Up to date. He was looking up to date. And his nurse was like, are you going to call the hospitalist? Like, what's going on? Call the medical folks. So he called me, and of course, we were able to address that concern. So my point is, that guy was extremely good with what he does. As a matter of fact, he delivered my first child. But somehow, in that moment, he needed some help with taking care of a pregnant diabetic. And of course, all he needed to do was call people who do that. So on the other side, like I said, breadth of scope for the generalist. Again, we like to think in terms of job openings. When you are a generalist, you are dealing with a large population, and because of that, there are more jobs available. I mean, I can't speak to the Nigerian situation in particular, but at least out in the US, there are a lot of, generalist kind of jobs. If you want to do outpatient as an internist, you want to do ER, you want to do hospital medicine, pediatrics, these things are relatively available. But let's say I go into cardiothoracic anesthesia. Like, fine, you're an anesthesiologist, but you really took your training specifically into the realm of open heart. You don't want to waste that education. But guess what? You can only work where there are openings. So if all the places are in jobless or working at a level that does not use all your education, and that could be frustrating. I mean, I've seen pediatric GI working as, general pediatrics. And I've also seen, again, a pediatric endocrinologist who had to move to a far place just because that's where the job was available. Like move your family, move everything, because that's the only place you could get to use your education. So your options are location-based. On the other hand, for a generalist, again, you have the volume. As long as the world keeps spinning, you're going to have people with uncontrolled hypertension, people with strokes, people with SLE, people with DKA. These are bread and butter things you're going to see wherever. I mean, COVID is just getting better, thank God. When COVID was extremely bad, of course, most of these clinics were shut. But for those of us who work in the hospital, we just had to keep going. We were like right there in the front of the battle. For a specialist, your advantage is that your patient population is predictable. Are you an ophthalmologist? You're going to keep dealing with pathologies of the eye. That's all you're going to do because that's what you want to do. And you can put all your energy into that. So there's none better or worse than the other if you look at these points carefully. With regards to the generalist, you do have what I call career path flexibility. So as I speak to you now, I have several offers to do different things, but it all comes down to what do I want to do? So if you look at a hospital, like a big hospital, and the administration, the medical folks on that board, most of them are in general practice because it's not so easy if you've spent so much time pursuing a specialty to say, okay, now I want to go sit in a boardroom and tell other doctors how to do their job or run the budget of the hospital and that kind of stuff. So there's more flexibility. If I want to still do something else now, I can, provided I'm willing to sacrifice the time. For a specialist, you're in there, stay there, and enjoy the ride on your lane. So I must not forget that there are specialties that are not involved in direct patient care. And please understand, they're not less important than those who see patients every day. In no way, shape, or form are they less important than the ones who see patients every day. So some people, they go into medical education. What do I mean by that? Maybe you start, even though you have you finished your residency and stuff, you still go to teach maybe preclinicals. You teach physiology, you teach anatomy. Some get into that. Some teach diagnostics, like what we would call CLI back in Nigeria. People do that separate from their clinical work. Some go into research. So with your medical degree, of course, you can either get into a MSc, MPH, PhD program, and you're on the the research part of things. Your goal is to discover more, to help add to the body of knowledge. That's excellent. Some people are into pathology. Of course, pathology deals more with tissue diagnosis. And so you're not going to be rounding on patients every day, but you're going to be making objective diagnoses based on the tissue that's in front of you. So all that's great. You could also be an administrator. Again, in this part of the world, it's quite different how that runs than how it runs back in Nigeria. So I'll defer to my colleagues on that aspect. And just like Dr. Adebayo was saying, public health. Because the place of public health education is so important. Just look at COVID. All of a sudden, everybody wanted to listen to what NCDC had to say, to what CDC had to say, what vaccines, how do I not die from this thing? That's because public health deals with the population. Not everybody's going to need surgery in a lifetime. Not everybody's going to need, a psychiatrist in a lifetime, but we're all going to need health education and the help of a public health specialist in a lifetime. So the question becomes, which is better? So look at those two bikes. If you look very carefully, one has the bar above and the other has that bar below. I think they call it step through and step over. So the one to the right of my screen is the step through. So if you're wearing like a long flowing garment, you can just step through it. You don't have to step over it. And the one to the left has it above. We're all used to the one to the left. That's the kind of bikes most of us knew growing up. The question is, which is better? I tell you, none is better, none is worse. Because when I was reading this up, you see that lower bar for the one that is step through is way heavier than the one that is step over, because they have to make it strong enough to sustain both wheels. So in other words, you may look at a generalist and like, how do you deal with this wide patient population? Well, he has his own benefits as well in terms of maybe the lifestyle or his hours of work and that kind of stuff. And the other side of the specialist also, you have predictability. You know exactly what you're dealing with, and hopefully you're enjoying your own specialty. So there's none better or worse. So Craig Mapp once said, if you can film an idea in your mind and follow that film idea shot for shot, scene for scene, that idea is worth making. So if you really have the ability to add 25 years to your current age and look at where you'd like to be then, and if you can see that in plastic surgery, by all means, become a plastic surgeon. If you can see that in, gynecology, by all means, pursue gynecology. So there's really nothing wrong with either going into, subspecialty, specialty versus primary care. And now these individual considerations. What do I want? What do I want? Understand that when it comes to success, there's always this element of individuality. Yes, your home, your family, your parents, your life, your background. Yes, all of that is true. We all are Africans. So that's important. But what do you want as an individual? What is it that you want? You have to be able to answer that question honestly. Number two, will I still want it when the sun stops shining? In other words, when it's not as, rosy as it is now, when you're kind of worn out, or when the conditions change, when things are more difficult. I'll give one example here. I have a colleague, he's much older, he's in his 60s. He trained as a nephrologist, but, he took this deep interest in helping people come off diabetic medication by diet. It just became a passion for him, and he started pursuing that. So ultimately, he started a clinic. He just started, getting people off their medication by very good, like Mediterranean diet and all that stuff. And he became very famous for that. Boom, COVID hit. When COVID, at least in America, when you're not seeing patients, you're not making money. When you're not making money, you're not paying your bills. So in his younger years, he had done hospital medicine, what I do. So guess what? He came to my boss and like, okay, I want to come back. I want to work for you guys. And he started and he enjoyed it. And as COVID got better, he's like, okay, I'm done. I'm just going to stay with you guys. That's what I was referring to when I said career path flexibility. So sometimes things change and you have to change along with that. But you have to ask yourself, before I step into that path, is this what I'll still want if things become much harder? What if what I need is different from what I want? And that's a much bigger question. I can't answer it for you. You got to answer it for yourself. So let's just wrap this up. It's not a lecture. Medicine is very prestigious, so you should be proud of yourselves for coming this far. Indisputably, it's a very prestigious profession. But medicine is not an end in itself. I'm sure you've heard that multiple times in this talk. I mean, in these series of talks, I meant to say. It's not an end in itself. You have to find fulfillment in your calling, and you have to find a calling that fulfills you. Those are two different things. Lane changes on the road can either spice up your journey or mar your journey. So my hope for every one of us is that looking back when you're now in your late 60s, 70s, looking back at sunset, your journey would have been worthwhile. Because medicine is just a part of it. Medicine should never be your life. It could be your means of livelihood, but it should never be your life. I want to share a somber story with you, not to upset you or scare you, but just so you realize what I'm saying is serious. There's a guy, or there was a guy, sadly, in my place of work. The guy studied electrical engineering in India, a very tough school to get into. He did it, came to the US, did electrical engineering over again, the first degree, came second in his university. After that, went to medical school here in the US. I hope you're following, 2 electrical engineering degrees, then went to medical school. Then he went to surgical residency. Then he went to cardiothoracic. So now we're talking about 20 years of post-secondary education. And we hired him. It's a new open heart program. Very happy to have him work with an older surgeon who's been here a couple years. Men and brethren, 3 weeks ago, he was found dead from apparent suicide. Extremely sad. I mean, I later found out this guy was actually in his 40s. I thought he's already in his 50s, but he was in his 40s. He spent more than half of his life studying extremely hard. And within 2 years of getting to the quote unquote zenith of his career, it was just too much for him. And he just died, killed himself. So my hope is that when the end comes, you're going to be able to look back and say, oh no, don't cry because it's over. Smile because it happened. May we all find fulfillment, whether we're generalist or specialist. That's my email. You can always shoot me an email if you need me to answer any questions. Thank you. Back to you, Dr. Adebayo.
Wow, was powerful, and you didn't use all your time. I would have hoped that you would have continued to go on, but that's fantastic. Of course, the sad story there. Why people? So, people, thank you so much. See, one of the interesting things I see about this our program, looking at the attendance list, I think we have more of our colleagues here than the people.
That's funny, yeah.
There are the people that we actually designed this program for. But I've been, and every time I've had to come in, I've been greatly encouraged and motivated. I know some of those skills that we learned back then, they have not learned how we palm things. So I'm not going to forget PPP that Dr. Akinola has given us today. The purpose, the passion, and the possibilities. I'm going to use it to preach. So, interesting life pattern. So I don't know if people have questions. If you have questions, okay, yes, okay, I'm told that they watch it. Okay, so maybe they have freedom over the other time, like we do. You know, a lot of us, we have a lot of time to play with now. So if you have questions, you have contributions, something that has struck you, Dr. Akinola has said that you'd like to put out there, or a contribution or a clarification, please just lift up your hands, go right ahead and say it, and just get into the middle of the discussion. So now I want to ask for your own, because one of the things people are interested in, someone asked me during the week, when I see your hand, that okay, if I want to go to America, I finished medical school, I want to go to America now, what do I need to do? What's plan? Is it USMLE 1, USMLE 2, 3, 4, 5, 6, 7? Is it up to 10 now? What do I need to do to get, before I start to talk about this either it's a generalist or a specialist, what are the things that I need to do?
Oh, okay. Well, the steps have not changed. The modalities of the exam, I believe, have changed over time, but it's always easy to get the information you need. I think the most challenging thing for people from our neck of the woods would be the visa part of things. So yes, there's step 1, there's step 2, which has both the clinical skills and clinical knowledge, and then there's step 3. So Step one, as everybody knows, is the, basic medical sciences, while step two is more of your peds, OB, medicine, psychiatry. And step three has to do with the management. Of course, how you manage is a function of where you practice. So I'm sure if I show up where many of my brothers or sisters are practicing today, within 10 minutes, I'm going to say something stupid because they're like, well, that's not how it's done here. So that's what step three tests. So if you really want to dig into the details of that, I think you should start with ecfmg.org. ECFMG, that's Educational Commission for Foreign Medical Graduates. So you can look that up. You can also look up emily.org. So those will be starting points in terms of the actual exams. Now, how do you as an individual do it? If you don't already have a connection to this country, then you're looking at either doing part of the exams in Ghana or applying for like an MPH or a degree that will grant you a visa to come in. So those are things that I feel might be a little bit outside of the scope of the teaching today. But yes, look at those websites. If you need more information from me in person, yes, I'll be glad to correspond with you. Thank you.
Thank you. Okay, Olubenga, Babi, please, you can unmute yourself and ask your question. Is Benga there?
Good evening. Good.
Benga, okay, please ask your question.
That you into hospital. So, hospital medicine.
Benga,
I'm so sorry, but you're breaking up, Dr. Alabi. You're breaking up.
Or if it's difficult for you to type, to speak, you can please go ahead and just write it out in the chat box. We would also attend to them. If your connection is making it difficult.
Thanks a lot.
Yeah, you.
You're
Thanks
welcome.
A lot,
please go ahead.
Still Benga. Yeah. Thanks a lot. You just want to, during the course of the lecture, you told us that you're into hospital medicine. So I want to really know what, this is the first time I'm hearing about hospital medicine. So I want to really know what it entails and like the duties, like what they do and everything. Thank you very much.
Yeah, you're welcome. So, well, I mentioned earlier also that as medicine evolves, some of these specialties kind of crop up. Things change along, like you'll hear things like breast fellowship, HIV fellowship. So hospital medicine is still under primary care. What it comes down to is you only work in the hospital. So my practice is internal medicine only focused on hospital care. So I work on, your regular medicine floors, pneumonias, NSTEMIs, cellulitis, psoriasis, all these things. Then I also get consults. Maybe the patient is having, how do I put it? Maybe constipation from the opiates. Maybe someone did a bowel surgery and gave antibiotics for 9 days, and now they have C. diff. So hospital medicine is essentially internal medicine focused on the hospital. You don't do any clinic. So I typically work maybe about 200 days a year, and some days, some admitting shifts when I'm in the ER admitting patients, some night calls, when I'm in the hospital, covering all the codes. But it's basically general practice in the hospital. That's all there is to it.
Great. So Dr. Akinola is a GP in the hospital, and in the hospital is there and taking care of things, making sure things are working well. Also, yes, like he says, also in administration. So beyond just the clinical part, it helps to set budget, make sure things, everything is working well. All right. So do we have any other question? Dr. Alabi, Bing Alabi, would have loved to hear from you. You can please drop your question in the chat box if we're having problems. So I don't know if our other colleagues and friends are here that want to say something, want to share something. Please go ahead. And at this time, I think we should also appreciate, I would take some time to appreciate the brains behind this initiative that makes sure that things are going on well. They've eaten themselves somewhere there, but they are there. Will I say, Dr. herself? Thank you. And of course, Dr. Gundia as well, Alaba Gundia. Thank you so much. It takes a lot of commitment to make sure that these things keep going on. The whole, making sure that people. Okay, go ahead, sir.
I see two questions popping up. The first question is, how far should a favorite lecturer influence your choice of specialties? And the second question is, in what way is hospital medicine different from family medicine? So the truth is, hospitalists exist from internal medicine, family medicine, and pediatrics, at least in the US. So the hospitalist thing is more of a, I don't know how to put it, more of a role than something you are locked into. So yes, I could easily switch out of it if I wanted to. Of course, family medicine practice is more outpatient. You take care of people from the cradle to the grave. That's what people like to say. So you do OB, you do peds, you do adolescent medicine, you do, again, internal medicine, female health, geriatrics. So all the what do you call it? The scope, the whole gamut. But it comes back to this point, your well-being, your well-being. I have colleagues who are in their 70s, they're older people. They've stopped doing what they used to do when they were much younger. Because what they used to do is when they wake up in the morning, they rush to the hospital and round on their patients that are admitted. After that, they go to the nursing home, see the ones that are there, and then go to clinic. And by the time they're done with clinic, if anybody newly has been admitted to the hospital, guess what? They go back to the hospital. Well, 21st century doctors don't want to do that anymore, because gone are the days that being a doctor makes you a king. You're not a king. You're just somebody who chose to care for sick people. So at least the trend in America is such that people like to take a little bit, take a little piece, do it well, and then live your own life. So once I go to the hospital and do my 12-hour shift, I'm done. I can go for conferences, I can study more, I can teach if I want, I take residents once in a while, but the quintessential family medicine practice with a whole scope is fading away. People don't want to do it anymore. So that's to the second question. To the first question, favorite lecturer is not going to live your life for you. Favorite lecturer is not going to practice your career for you. So a point has to come in your own life where you have to say, this is what I want. Remember, there was a slide where I said individual considerations, and it's really tough when everything is down. Will I want it when the reimbursement from insurance is gone? And what if what I need is different than what I want? I mean, these are questions that Miss Lecturer, Mr. Lecturer cannot answer for you. please don't get me wrong. Your teacher can motivate you. You can respect an ophthalmologist so much and you want to be what she is. Excellent, go for it. But make sure it's your own passion that's driving you. You're not doing it simply because, oh, great physician, great ophthalmologist, I want to be an ophthalmologist like her. No, you desire that. You're ready to pay the price. And I see a third question. Okay, this person says, I've always had a vivid image about what specialty I wanted after medical school, looking at how much medicine evolves and what might be obtainable when I get there. How do you have any way I can seek clarity? Well, it still comes back to those P's. And I'm a little flattered by Dr. Adebayo saying he's gonna use it in his sermon one time. So bottom line, you have to know yourself, okay? If, let's say, just for example, if you came through a lot on the home front and so many people are expecting our doctor to become something for us so we can at least have some respite, I'm talking about your own family now. If you now want to go into a specialty that will take another 20 years, another 15 years of your life, you're not being fair. Fair to your parents, fair to your uncle, fair to your siblings. So that's where pragmatism comes in. The other part, obviously, is if you want to travel, then you have to also consider that you're not at the same level of consideration as those who studied in that system. You're not worse than them, but you're not considered at the same level. Why? If somebody goes to medical school in our own country, Nigeria, most of the times our parents take care of the bill. God bless them. In this part of the world, $350,000, $400,000 loan. So you score the same mark, you have the same capability, sir, they're gonna give them that juicy colorectal fellowship before they give you. If you now say, oh, I have to go back fellowship, it's your choice. It's your choice, really. So what I would say to this doctor is start from where you are and excel at what you're doing now. And in the course of your patient care, you're going to discover what really clicks with you, what you really enjoy. Some people don't enjoy direct patient care as much as they enjoy making diagnoses. Did I talk about pathology? What can I do without the help of a pathologist? Not very much. I was reading a case report recently about how a case of pyoderma gangrenosum was misdiagnosed as cellulitis. They kept giving antibiotics. It kept getting worse. This is something that 5 days of steroids would have taken care of. I don't remember well. They might have done a wrong, what do you call it? A wrong amputation on this guy because they thought, oh, it's necrotic. We got to remove the leg. But if you take that biopsy and you send it to Dr. Mike Tanimowo, he's going to show you, oh, this is pyoderma. Give them steroids and they'll be okay. So at the end of the day, you, the individual, have to figure out your purpose, your passion, and your possibilities.
Okay, so we have our people here, our comedian has entered the group. We welcome you, Bari. Well, so Dr. Akinola has answered the questions beautifully. You won't say because OAU was very, very interesting to you in ONG, you now choose ONG. You may love ONG because of its introduction, but ultimately it has to be your choice. And you must remember that that decision is yours. I know some of our, even at our own age now, some of our people are wondering, have I made the wrong choice? What am I doing? And so people they are jackpotting now. But like I said, pragmatism need to come in. What can I do now if I leave? How many years am I willing to put in after now to now go through the org before I can say I am a doctor? in the United States? Can I do 10 years more? By the time I'm 10 years and I'm 55, is that going to be I'm 56 or I'm 60? And I'm saying I'm not the key, but so pragmatism is very important. So I don't know if we have other questions, any other contribution that we need to put in.
If possible, I'd like our colleagues, maybe Dr. Olasende or other colleagues back in Nigeria who can help us, just to add another perspective.
All right. I'm tempted to call him the name I used to call him when we let him call him that. Okay, so Dr. Olasende, what are the options now available? From what we've seen over here, so there's so many, so many specializations, specialization of the eyelid, specialization of the eyeball, people there, because there's so many subspecialties. But yeah, but now I think we're having some of those specialties come in. We don't yet have headache, we don't have headache neurologists, yes, but maybe because we don't even have enough neurologists now to say we want to have somebody that specializes in headaches. So, Dr. Lasende, what do you have anything you'd like to add? What's happening right there at the center at OAUTHC? What other specialties are new?
Yeah. So maybe first I'd want to thank Prof for this very beautiful talk. I enjoyed every bit of it. And sincerely, I would say that even though the nomenclature may differ,
oh, I think we are losing Dr. Lasende there.
You do have over there, okay. But
oh, it's gone again.
Oh.
Okay, I think Dr. Lasende is speaking, but what he's saying is that, what if I could pick a little from what he's saying, is that there is not more difference between what's happening, that maybe there's some improvements in generally structure and the specialization structure that we have right here in Nigeria. All right, so do we know anybody else want to say something about I know we have Dr. Adebayo somewhere here. How did you cope? Dr. Boli, please, how did you cope during COVID? Were you still, did that shut your clinic? Did it shut down? How were you able to manage? So somebody may be wondering, because you are a super specialty cardiology, and of course, so do you have anything you want to say, sir?
Hi guys, hello everybody. Great moderation and great presentation, Aki. The type of work that I do, unfortunately, we can't shut down. My bread and butter is treating patients that have heart attacks. Although the numbers went down during COVID, and the reason why they went down is because people were actually more scared of COVID than they were scared of coming to the hospital because they had a heart attack. So people were staying at home. And, unfortunately, the numbers went down. Also, we stopped doing outpatient procedures, and outpatient procedures are people that have stable heart disease, having chest pain and things like that. You stop bringing them in. And the only way you could do that was you tell the patient, if you're having chest pain, go to the ED. And then they'll bring them in from the ED, but everything was shut down. So the numbers went down, but we didn't really shut down. We shut down clinic for a while. And that was, COVID started when I was still in training, actually. But we didn't do much. We still opened the lab, we still did emergent procedures, but the numbers went down because everyone was worried. But there was never a time that we totally shut down. Maybe a few weeks, but that was about it.
Okay, great. So you heard that. So if you want to go to a field that will not shut down, go to the one that when people are asked to stop working, they must still come. But you are still scared. I think one of the things that I will take away from here is that whatever you want to do, please do it quickly. Anytime somebody asks me for advice, I want you to travel, I want to do this, I want to do that. Whatever you want to do, whatever it is you want to do, you're a young person there, you just finished med school, get that purpose, that question of purpose, very, very important. When I said it, these things that we are sharing, there are things that people pay to learn, and then some people learn too late and discover that, wow, how did I make this mistake? Whatever it is you want to do, please do it quickly. Get that question of purpose, get it answered very quickly, and then sort yourself out. I don't know if we have any other question. I don't know if Dr. Akinola has final words that he wants to share, things that you just want to say finally to people, that this is important. Let's get to, as I close, just final words that you'd like to share.
I think you've said it all, and we're here to support you. Everyone's journey is, unique. And again, referring to our previous colleagues, you just heard Dr. Adebayo, I believe Dr. Sashin was here, a lot of people, Falabi, many people have spoken. So your path should not be a, Xerox of someone else's path, but just like Dr. Adebayo said, get on it, just start. You're gonna have some trips, some setbacks, but sometimes those trips are actually the signal to switch your path. And before you know it, you're excelling. So I wish you all very well. And yeah, don't hesitate to send out an email if you need me for anything. Thank you.
Thank you so much, Dr. Akinola, and thank you everyone that has been a part of this. As we shared earlier, this will be put up across all the social media handles. You can reach out to the official email. It's just in the chat room now. In the chat, the official email, send emails to OAUMed05@gmail.com. Some people have reached out, some people continue to reach out, so please send it there. And when all is said and done, let's finish with the great words that Dr. Akinola gave to us. medicine, it must not be your whole life. If all your life is all just about medicine, then that life has not been, how we say, has not been a very fruitful life. There needs to be more. There must be more. There must be a reason for medicine. Medicine is just a part of that life. So I sign off here and hand over to our OAUMed coordinator, Dr. Nubia. And I think there'll be party after party.
Fellowship after fellowship.
We can call each other by names that we really know. All these so that we can report to them. Thank you so much. God bless.
Fellowship after fellowship. See you later.
Thank you so much.